Good evening, everyone. Thank you so much for joining us tonight for our latest medical sciences lecture. The title is Virtual Reality in Healthcare. My name is India Dean Smith. I'm a current medicine student here at UCL and your chair for today's event. In today's fascinating lecture, Professor Rui Loureiro will discuss about how sensorimotor interventions are shaping rehabilitation outcomes and clinical surgical training. We want to keep these lectures as interactive as possible, so please use the Q&A function on Zoom to submit your questions for our speaker, Dr. Loureiro. The hashtag to use on Twitter for this event is hashtag FMS Lectures, and this lecture will be recorded, and a link to the recording will be sent out via email to all the attendees after the event. Before I introduce our speaker, we would like to know a little bit about our audience. So we're going to run the following poll, asking you to select the group you consider you belong to. So the options are prospective students and their families, undergraduate students, PGT students, PGR students, PhD students, academics, patients and carers, and any other. So we'll give you a minute to fill out the poll now. Thank you so much to those that voted. So we have 47% of the audience are prospective students and their families, 19% undergraduate students, 6% PGT, 6% PGR students, 3% are PhD, and 19% are any other. So thank you so much for voting. I am delighted to now introduce our speaker. We have Professor Rui Loureiro. Professor Rui Loureiro is a professor of surgical and rehabilitation engineering at UCL and head of the UCL Institute of Orthopedics and Musculoskeletal Science and of Aspire's Center for Rehabilitation Engineering and Assisted Technology, also known as CREATE, at UCL. He specializes in advanced robotics and human interactive systems for surgery and rehabilitation. Thank you, Professor Loureiro, for joining us today. Now over to you.
Thank you for the warm welcome. For over 2 decades, there has been a growing interest and activity to explore the use of virtual reality and robotics in rehabilitation and clinical, mainly surgical training. In rehabilitation, the model is to incorporate robotic assistance designed to enhance recovery following injury. In this model, it is expected that the robotic system will be made available possibly during the patient's hospital stay or in the months that follow. In surgical training, the model is to optimize personalized clinical procedures by facilitating co-development of new surgical techniques and the tailoring of difficult patient-specific interventions. In this lecture, we will look at new ways of using VR and robots through a gamification paradigm for clinical training, and will demonstrate how strategies that aim to trick the brain can have a positive impact on the recovery of cognitive and physical injuries and in reducing pain. So without further ado, today virtual reality technology is applied to advanced fields of medicine, engineering, education, design, training, and entertainment, to name a few. It incorporates mainly auditory and visual feedback, but also allow other types of sensory feedback like haptics. VR is in essence a computer interface that tries to mimic real world beyond the flat screen to give an immersive three-dimensional visual experience. Often, it is hard to reconstruct the scales and distances between objects in static 2D images. Thus, the third dimension helps bringing depth to objects. There are 4 key elements to VR: a virtual environment of the world, which is an imaginary space often, but not necessarily, manifested through a medium. A computer-based virtual world is the description of objects within a simulation. There's immersion, and more about this in a moment, but in essence, is the feeling that you are within that environment. And third, sensor feedback. There are several kinds, lots to choose from, and we will explore those in a little while. And fourth is interactivity, how to respond to user actions, in what way. The virtual world can exist solely in the mind of the originator and need not be broadcast to be shared with others. However, if the virtual world exists in a computer, it is essentially a piece of code that describes objects in space and the rules and relationships governing the objects and how they relate to each other. Now, this story of virtual reality goes back to the 19th century. And it was really in the 1930s, particularly with primarily on Spectacles, which is a short story by Stanley Weinbaum, who presented the idea of a goggle-based virtual reality world through holographics, smell, taste, and touch, making him a true visionary of the field. In the 1960s, I think the landmark was with Ivan Sutherland, who created the first VR headset with specialized software and motion control platforms, which became standard for training. And in the 1990s, we saw gaming developers such as Sega and Nintendo coming up with new ideas. And certainly the Nintendo Virtual Boy marked the walkthrough of VR in the public domain. It was first ever portable console displaying true 3D graphics for gaming, but lacked software support, and it was very uncomfortable. Now, you might remember The Matrix in 1999, that game, that was truly a movie that inspired the VR community. The film featured characters living in simulated world depicting VR. It was major cultural impact and introduced VR as a mainstream. In the 21st century, we saw the boom of smartphones with high-density displays and 3D graphics capabilities has made the new generation of lightweight and practical VR devices very possible. I can tell it was a completely different story when I started this journey of developing VR applications over 20 years ago. The video game industry developed consumer VR, which is innovative. Depth sensing cameras, suits, motion controllers, and natural human interfaces are already in the market for daily human-computer interaction. But it was in 2014 when Facebook actually bought up Oculus VR and started developing VR chat rooms for the future that things really started to take shape. And in 2016, the burst of different VR devices into the commercial market was just phenomenal. But no one has got a clear definition of what VR is, about what VR isn't. Telepresence, for example, where we see the use of cameras, microphones, etc., substitute user senses to allow the user to interact with the remote environment could be VR. Augmented reality graphics, in this instance, are overlaid on top of real images. But both real images, both of them use real images, so not strictly virtual. Films, on the other hand, actors don't interact with the effects, but they don't even think the effects are real. So virtual reality is an interactive computer-generated experience taking place within a simulated environment. Augmented reality, on the other hand, may be considered as a form of VR that layers virtual information over a live camera feed into a headset or through a smartphone or even a tablet device, giving the user the ability to view three-dimensional images. We've seen with the history of aviation, the history also of simulation, and with that VR. It was the need of training pilots as airplanes became more sophisticated, more complex to operate. The need to train pilots safely without them flying and destroying the airplane, a need and an emergence of VR technologies. Today, we see VR in many different fields, in entertainment industry, games, social, vehicle simulation, flights and cars, ergonomics and design, buildings, cars, testing for safety, testing before you even build. Lots of senses, sounds and acoustics in buildings can be simulated in VR. Rehabilitation of phobias, this is good because it's controlled, and post-traumatic stress disorders. In training, difficult to recreate scenarios. And, for example, how do you train astronauts without going to the moon? Vets, dentists, manual skills, complex surgical skills, and also in communication interaction, so collaboration. By immersing patients in virtual environments, virtual reality can provide a more engaging and interactive experience and can accelerate the healing process. Patients can perform exercises in a safe and controlled environment with real-time feedback and progress tracking. Now, VR technology development for rehabilitation, can be, in essence, traced to three main periods. The first period was when we saw the mainstream VR technologies coming to be. The initial development work in the research labs began, and we saw a multitude of accessible rehabilitation settings exploring the possibility of using the technology. The issues in rehabilitation at that time was the need for more precise, lower weight, lower cost hardware to bridge the gaps between goals and of basic and applied researchers and developers. The second period, what we saw was customization of rehabilitation prototypes. Was the emergence of commercial clinical-oriented devices and development of commercialization of fairly low-cost VR systems. The issues then was reliability, validity, transfer of training of studies into outcomes. The third period, which, the slide suggests is ended in 2018, I argue we're still in it, is about development of high-end and low-cost systems. It's increased the ability of embedded ambient VR technologies to monitor the real-world activity, and what's also to do is the proliferation of low-cost turnkey VR systems with clinical validity and reliability. And is on increasing the focus on VR applications with a personalized medicine approach. The issues in rehabilitation are how using VR as a paradigm for posing questions of relevance to motor control, to motor learning, for example, validation of movement kinematics using VR, studies showing how VR technology addresses treatment effectiveness, and so on, and exploring of novel clinical interaction paradigms with VR-supported technology. We have seen an absolute explosion of publications, scientific publications in VR. If you do a search in Google Scholar, you will see exactly what I mean. Just type the words VR and rehabilitation as your keywords and you will find. What is interesting to note, though, is that when we look at the three periods, the first period, the focus has been mostly on addressing cognitive issues. Telerehabilitation, how can we get people remotely engaged in rehabilitation paradigms? It was about the simulation, it was about psychological issues. The second period, although this was still part of it, the focus was more on neural impact, was more on gait and balance, was more on perception and navigation. The third period, we saw now an increased focus on gamification, on how we can make serious gains beneficial, on neurological conditions, on interventions that translate to clinical outcomes. So forgive me for talking about my own research, but I'll do so as an example of how we are using and developing VR technologies for healthcare at UCL. We've been developing VR and robotics for pre and post surgery, a simulation platform for the training of complex surgical skills and the subsequent planning of procedures that might be a first time that the procedure is implemented, to solutions for pain management, solutions that, for example, trick the brain into believing, for example, in an amputee that the missing hand is back, and using that as means of managing their pain. other technologies that use the combination of VR and robotics, for example, to alleviate the symptoms of spasticity, and how we go full circle with this. And by thinking outside the box, VR has allowed us to come up with things like frugal bionic devices for individuals with who have lost a hand. So let's jump into the journey, shall we? I'll start by tapping into surgical training and motivation for change. It is widely accepted that computer simulation will become standard practice in clinical skills training, and it's now, as it is now with the aviation industry. Top-level decision makers want clinicians to train using simulators, and clinical simulation research has not translated to practice. Current solutions are too expensive, limited in functionality and scope, difficult to maintain and update. But medical simulation did not gain widespread acceptance in the recent past, principally because for the reasons of high cost of those simulators. Major constraint for the medical simulation market is the increasing cost of these simulators. Current best practice relies on actors, on mannequins, on props, which create variable fidelity experiences and lack objectivity. They also incur high costs. They are restricting the range of experience. And when it comes to role play, actors, it's very difficult to find pathology. And the experience varies every time. With mannequins and prosthetics, for example, there's limited scope per mannequin. You might be able to train a specific procedure, but that's about it. So there's the high initial and recurring costs associated with those two. I started this journey back in 1998, looking at VR solutions. And back at that time, we were developing technology without the technology push, so to speak. The smartphone push came afterwards. So as you can see here in the videos that are running, we develop simulators for minimally invasive surgery, which in this instance is, so you got a human torso and you can interact with the different tissues and feel the physical properties. So we model the physics of the tissues as you would expect in the real world in the virtual domain with very crude graphics, as you can test for yourself. But the point was we were mimicking the experience that surgeons have when they interact with surgical instruments, namely laparoscopic devices, and manipulate tissues. So we could, through force feedback, we could mimic and make the user feel as if they are touching a tissue. Fast track to today, what we've been developing at UCL is the SpeedUp platform, which is a simulation platform for the development of new surgical devices and optimization of personalized clinical procedures. It's a mouthful, I know, but what it aims to do is to aid the development of novel surgical tools and techniques, allow you to optimize personalized procedures while providing realistic simulation that allows concepts from technological solutions to be tested virtually before moving into physical prototyping. This is aimed to facilitate the co-development of new surgical techniques and tailoring of patient-specific interventions. Let me give an example of how we do it. Take complex hip revision, for example. We take imaging data such as CTs and MRIs, and we segment the data, and from that, we create accurate patient-specific 3D models. Those 3D models are used to reverse engineer the anatomy and develop patient-specific implants, in this case, a hip. But we also create interactive models for restoration simulation, and in simulation, we simulate collisions, we simulate the virtual models, the deformation models, and all the physical aspects of how you interact with those tissues. Then These are all uploaded to our simulator, where surgical teams can step-by-step plan and allow them to have hands-on practice using patient-specific data before they go into the operating theatre. That means that they're able to practice plan A, B, or C and execute plan A, B, or C and know exactly what the challenges will be. So when they go to the operating theatre and they are executing plan A and things change and they need to move to plan C, everyone knows what to do. One day, we hope this will lead us to have intelligent surgical tools, maybe even robots, that are going to help the surgeons, guide the surgeons to minimize risks and with the aim of improving patient outcomes. So what our simulator allows us to do is, so we can take patient-specific data, we create the patient-specific models, and we can upload it to the simulator. We can assign tissue properties, constraints, and so on, step by step, build our simulation, including the metrics, including the surgical instrumentation that is being used and how that surgical instrumentation is going to behave, so the dynamics of it. What we are also able to do is to provide this as a training environment where you might have a surgical team of 2 or more interacting in the same environment. And you can see the video being played, which shows one of our current prototypes in the lab. And what you are seeing is we can seamlessly move between virtual reality to augmented reality. And you will notice this augmented reality because you will see all of a sudden that you have the background, the noisy background with many things happening in the lab superimposing to the virtual domain. And what you are seeing there is this happening through the eyes of a third person who is watching the operator using the surgical instrumentation to physically interact with the virtual models and feel as if they are interacting with a real patient with real tissues. What we are able to do as well is to provide multi-user touch interactions. And this is just a little bit of fun. It was an open event at the Device Center. And what you see in the video on the left is 2 users interacting with one of our robots. And their task is quite simple. They have to, they've got the rope and each have to move the rope. And as I pull the rope, you will feel that pull. And together they need to wind the rope around what it looks like some floppy material. While they're doing that, they feel all the forces, all the interactions as you would expect by doing this in the real world. So we had to create accurate haptic feedback models of hard tissue, bones, and also deformable soft tissues. So we have the building blocks from the software point of view to allow you to perform simulations such as this, where you might be interacting with an artery, or you might be practicing performing an injection or an epidural, for example. But in doing so, you feel physically as if you are interacting with those tissues. Sorry, just to say, what we also do besides the software is develop our own hardware, and here the video playing is an example of a haptic feedback laparoscopic device which mimics the real surgical instrument and provides force feedback as you, for example, grasp the tissue and pull the tissue. We've been using this to also teach surgeons how to put together a simulation. Here's an example of one of our MSc students who carried out the MSc program in advanced minimally invasive surgery, who taken MRI images and did the segmentation work and created the accurate 3D models, patient-specific 3D models for the training of percutaneous ablation of lymph tumors. and implemented this within 3 weeks. So we have a number of different studies underway, ranging from procedures on colorectal cancer resection to foot and ankle arthroscopy, to lumbar endoscopy discectomy, to hip replacements, to learning how to manipulate the baby head on the birth canal to aid a complex or difficult delivery safely, and so on. With that in mind, I will just give you an example. So this is a study which we are collecting currently data. In fact, we'll be collecting data this Friday with trainee obstetricians. And often what you have is a case study, and this is manual rotation. This is a case where there are complications during birth, and the team has had to perform what they call manual rotation, which is manipulating the baby's head safely into a position which they can then, for example, use forceps to aid the birth. When things, so you want to be able to do this because you want to avoid further complications which could end, in C-section or worse. And so what you have is the video on the right is showing how it's done with the mannequin. And the problem with this is that you don't know exactly how well the trainee is doing, if the trainee is acquiring the skills needed. And on the left, you can see one of our simulators at the moment, where we use a model of a baby head as a phantom to give you all the interactions that you would expect when you are manipulating in a very confined space the baby head safely. And so we are able to measure the way you grasp with all the forces acting on the baby's head, and we're able to tell you precisely how well you perform the procedure compared to the gold standard. And we hope by doing this, we will be able to train more clinicians to develop the skills that are needed for such a life-saving procedure. So now I would like to transition to the rehabilitation side. Underneath it all is the same technology that we've been developing for surgical simulation, the same VR and the same robotic technology, applying in a different way. And we've been doing solutions for neuropathic pain management. We look at peripheral nerve injury and treatments for neuropathic pain, and we're using VR and robotic technology for that treatment. And we'll also be looking at ways that we can augment the sensory map while managing pain. We've been developing this since 2012, and we started our first human studies in 2015 at the Royal National Orthopaedic Hospital, and there's a lot of people involved, and clinical collaborators facilitating the work. We have looked at open limb amputees, spinal cord injuries, limb damage, nerve damage, and also started to look at lower limbs. But if we start with the phantom limb pain as our starting point, phantom limb pain is a chronic pain condition, which is defined as painful sensation often in the missing limb. So this occurs in all people with limb loss and absence, and with the majority of traumatic amputees suffering from painful sensations. And these sensations can be anything, can be from pins and needles, can be burning sensations, you name it. And the best way to describe it is just if your hand is itching, what do? You probably do what I do, is you go and scratch it, right? But sometimes, I try to resist the urge to scratch, and 95% of the times it doesn't work. I'm going to go and I just overdo it. Now, imagine this scenario, but you have no hand to scratch. So because you have no hands to scratch, you have no way to, address the sensory overload, and therefore pain increases. And that's very much what is phantom limb pain. There are several debates as to the origins and mechanisms of abdominal pain, but we believe that this is multifactorial. It's a process that's driven by anatomy, by psychology, social factors, and so on. And of course, it's comparable to other chronic pain conditions as well. Most common contemporary treatments involve pharmacological interventions with mixed results. Sometimes further surgical revision is needed. But the Biromox therapy has been the one most used with mixed results, however, with very few side effects, which has been translated to a virtual reality domain in the mid-2000s. Although this was a direct translation of traditional mirror box therapy with non-effectively controlling the mirror actions of the affected limb. But what is missing? Well, recent publications seem to suggest that in addition of sensor feedback is what is missing. And that's exactly what we're doing with our system. So what you see here is one of our patients that has undergone our clinical study. And what this patient is doing is, through the virtual reality headset, is seeing the missing hand back. Okay, he's got the residual limb connected to one of our robots that follows the movement and maps this movement into the virtual space. So you have a first-person view of the virtual environment. And what we also do is take signals from the residual muscles through EMG to map that into open and closing of the hand. Now, that allows them to control. And then through the robot, what we do is every time the participant picks one of those cubes, feels the physical properties of those cubes. In other words, it feels the weight, it feels the friction as they drag the cube on the table, and they feel the collisions between the cube and other cubes. And this has an impact in reducing pain. So we have started our clinical studies in 2015 and use a similar protocol for the studies we have been conducting thus far. We have an experimental group which uses a virtual surrogate for the missing limb with force feedback, and a control group which receives exactly the same but without force feedback. We use a range of different outcome measures, being the Mejio Pain Questionnaire, the primary outcome measure, and then we have other secondary outcome measures. The study timeline starts with initial consent. Once that has been obtained, we have a preparation session where we set up the sensors, the MG pattern classification. We do the initial pain questionnaire, and the pain diary is issued. Then the intervention lasts 3 weeks. And so we perform 9 hours of therapy in total. That is 3 hours a week. And at the end of each session, we measure drift, we measure pain, we measure embodiment, and we collect all the kinematic and kinetic data through the robot. Once that initial 3 weeks has ended, there is a further 3 weeks of no interventions. And then we perform follow-up measurement sessions at 6 and 12 weeks, where we measure whether the pain gains have been retained or not. So this is just to summarize some of those results. We've been looking at transradial as transhumeral amputees with different levels of pain. But the main point I want to raise here, in the interest of time, is that although all the two groups have benefited from the intervention, the group that received force feedback benefited the most, with 66% pain reduction per session, overall 64. So for us, this is very encouraging, and it's been the subject of further funding, further studies that have started since. We're looking at additional populations, patients with spinal cord injuries. We completed a case study. We have a few others that we are about to start. We'll be using the system also, in addition to providing the intervention for pain, also to recreating the hand and digits on the stump to potentially aid myoelectric prosthetics control, and also with upper limb nerve damage and subsequent pain, which could potentially lead to an amputation. this is the participant with spinal cord injuries, and I think what I will summarize it in this way: there were no overall negative effects, and the pain, although the pain relief was inconsistent, there's very little pain or no pain during sessions. For this particular patient, what was interesting to note is the patient was reporting 4 phantoms, although half the limbs. I was reporting 4 phantoms in awkward positions, and that was creating stress and pain and so on. Through the improvements that we observed was better quality of sleep afterwards, and importantly, she was able to align the phantom limbs with her real limbs, and we saw an increase in active range of motion of 30%, which is phenomenal when you look at a patient with spinal cord injuries. The nerve injury patients, very interesting initial results which we are looking into. But we recreated the phantom sensation area in the stem lateral aspect, and also in the area of the stem medial aspect. So what you see in the video is the researcher is stimulating the stem by applying brushing strokes on the stump. And in the VR, what the patient is seeing is that same, in synchrony, that same brushing through a digit, maybe a finger, maybe a thumb, and so on. And by doing this, what we're starting to see is that generalization and the cortical map starting to emerge, which we believe will have an impact in particularly brachial plexus injuries, to increase the sensory stimulation. So to conclude my talk, what we've learned a lot with the VR over the years, and there's a lot to be done still. We have also been thinking outside the box, and we actually look at a specific problem. One of the patients that was on our study and completed the study, I think, was after 8 months, had further complications, nothing to do with the study. And our clinical team, our neurosurgeon, saw the patient and asked us if we could offer the VR intervention again, which we did, to bring the pain levels back down. And then he was adamant that he felt in his clinical capacity that this patient would benefit from having a bionic hand. And so we did try to get a bionic hand for this patient on the NHS, and we're talking about 40,000 to 50,000 pounds worth of equipment. And she would be on a waiting list for 3 years. So that wasn't really something we considered to be acceptable. So we decided to take a open access design from Open Bionics. We modified it, we modified the electronics, and we transferred what we were doing, the myotic control that we were doing in the VR, to this low-cost electronics. And so here is the first times that we were mapping the muscle information to open and closing of the hand. We also scanned the stump. We 3D printed the line and a socket, and we delivered this to the patient before Christmas, about 3 years ago. And the idea with this wasn't to increase and improve function, was to allow the patient to self-manage their pain. And our neurosurgeon was absolutely correct. Pain levels went down, and really, really nicely done. You will notice the 2 videos on the right, which are all odd shaped. They were sent to us via WhatsApp from the patient's home. And the thing that we are really excited by is, by thinking outside the box, you can develop a frugal technology such as this, which costed less than £4,000 and took us less than 3 weeks to develop. and could potentially be saving the NHS for this patient alone, or lifetime ongoing treatment costs of over £500,000. So I'll leave you with that. Thank you very much for your time to listen to me. I'd like to say none of this work would be possible without the support of my colleagues and collaborators at UCL, at Aspire Create, at the Royal Orthopaedic Hospital, and all the other institutions we work with, and our funders. Without their funding, we wouldn't be able to do the research. And a big thank you to key people, our clinical collaborators, importantly in the lab, Peter Snow, Elliot, Irving, Tiana, Rennie, and many others, which have put their I think we're very lucky as well. We have a talent pool that is second to none. So thank you all.
Thank you, Rui, for such a fascinating lecture. That was great. And now we're going to move on to the Q&A portion of the webinar. So do send in questions using the Q&A function and we'll be able to answer them. Just to start off, we got some questions before the webinar. So in advance, we got the first question: what studies or courses would you recommend to someone who wants to work in this area?
Ooh, so I'll tell you how I got into this myself. I'm a cyberneticist, so I bring biology and technology together. And I think my source of inspiration has been my late father, which was a physiotherapist and wanted me to do medical school, and I ended up being an engineer. So do biomedical engineering. That's my answer.
Okay, great. Our next question. So could VR simulation help medical students practice sutures and other skills and procedures?
Absolutely, we're doing it already. So the answer is yes, but also I think is definitely the simple procedures, but I think where this technology has great promise is in complex procedures where there's great uncertainty whether or not the procedure will work, and the surgical teams need to try different ways of doing it, basically.
Okay. Our next question is, I know this is about virtual reality in healthcare, but what are the possible health implications of using immersive virtual reality for prolonged periods of time?
Absolutely, and that was a question that we got asked when we started our research journey with the ethical committee panel, and the answer is, if you asked the question over 20 years ago when we started, we didn't have the Oculus Rift and the headsets that you can buy now for £200. And the headsets we had then were that big, very bulky, big, and the screens were awful. You would be wearing them for 5-10 minutes, you will have a headache. That would be a big problem. That would be a big no. Nowadays, because the technology is fantastic, it's not so much of a problem with motion parallax or dizziness. However, our approach has been, you don't want to overdo it. So although, for example, with the phantom limb plan, although it's 1 hour session, is not 1 hour of continuously wearing the headset. We take breaks. So we might be having 10 minutes of intensive exercise, then we pause for 2 minutes, take the headset out, pause for 2 minutes, have a breather, and we have a glass of water and so on, and then go back to it. So it's managing, as with everything to do with technology, too much of it might be detrimental.
Great. Our next question is, has auditory feedback been added to the visual aspect of virtual reality in rehab? And if so, what were the observations? And if not, how do you think it can work out in terms of improving the rehab process?
So, okay, definitely, and auditory feedback is really simple, and so if we look at the surgical aspect, you can simulate the noise of the surgical tools. For example, if you have an orthopedic drill, when you're drilling on bone, not only feeling the vibrations of drilling, but also the noise of the drill and the bone and so on. In the rehab, yeah, it depends on how you the scenario that you present. So part of your rehab paradigm might be, someone is exercising and relearning how to walk and then doing that in the park. And you might have, you know, the noise or the beautiful sounds, shall we say, of birds singing and flying by, of dogs walking by, and so on and so forth, of people and so on. So there's so many possibilities with the auditory, combining auditory, visual, and haptic cues. That we barely scratching the surface. And there's one extra which we haven't talked about, which some people have been proposing, is what about smells? And smells do have a very important aspect in the feedback system, and considering that we interact with the world in a multimodal way, we use smell as well. We use smell, we use vision, and often vision dominates. But as I often say to my students, haptics calibrates, because I don't know if you can see, I've got my bottle of water here, and I can tell you just by looking at it, I'm sure you can as well, but it's half full or half empty. But unless you hold it in your hand, you don't know precisely how much it weighs. So it's that symbiosis of the multimodal aspect of how we interact with the world that I think is very exciting to explore further as therapeutical interventions.
Yeah, definitely. So another question that we got from before the webinar is, with artificial intelligence on the rise, will this new wave of robotics threaten medical jobs? And if so, is this a necessary sacrifice to improve the efficiency and accuracy of our healthcare system?
So my answer is no. I've been developing this for over 25 years, over 25 years. And I don't believe the robot of the robot physiotherapist or the robotic surgeon. I believe in advanced tools that can be used by the professionals, the healthcare professionals, and they are the ones that choose how to use those tools and with whom and the circumstances of how they're going to use it. For example, early on when we were looking at how we do robots for stroke rehabilitation, which I didn't talk about today. Early on, we talking about the year 2000, so 23 years ago. We literally were about to start a study with using robots for stroke rehabilitation with chronic strokes. And we had a questionnaire of about 30 questions, more or less, can be precise. And we asked, I think it was question 10, or thereabouts, would you use a robot for physiotherapy? And we have the questionnaire sent out to, practitioners, clinicians, physiotherapists, family members, you name it. And 90% said no, not to a robot in physiotherapy. Further down the line, I think it was question 20 something, we asked exactly the same question, but with different wording. And we asked, would you use a computer assisted device or system for physiotherapy? 70% said yes. So it's all about perception of what technology can do for you, what are the limitations of technology. I do not believe the robots can replace physiotherapists or surgeons, because there's so much of those intrinsic skills that we simply cannot get robots to do. Someone would argue AI will change all of that. I think AI will hope that AI will change things for the better, in the sense that will allow us to improve our decision making, and clinical decision making is really hard and really stressful. And if we can have AI solutions that will allow the clinicians to make those decisions more objectively and precisely, that's a good thing.
Great. And our next question is, what were the barriers to implementing your research ideas and practicalizing your theories, and how did you overcome these barriers?
Oh, so many. Remember, this is not my work. This is a big team's work. Okay, and there's a lot of talented people involved, and the barriers have been with any technology is how do you get the clinical profession or the NHS, for example, to adopt the technology that you're developing. And the problem we have is a problem of clinical effectiveness. How do you prove it? And when you compare to how we do it with pharmacology, so drugs, how drugs get approved, is they conduct huge trials with 10,000 people and so on. And it's impossible to do that with humans, with robots and technology, because of the logistics of running those trials. It's not the same thing as giving someone a pill, which is a placebo or not, and then evaluating whether or not it has had an impact. So those are the barriers. And I think also is in developing technologies is, and I think it's for us in our as Aspire Create is a big motivator, a big driver of what we do is we want to see our technologies beyond the research room. We want to see them out of the research lab. We want to see people benefiting from what we do. So is translating the research equipment into products that are not overly expensive, that are affordable is very, very, very challenging. But it's something that we are working towards.
Great. So our next question is, do you think it is feasible for virtual reality and haptics to be applied to something similar to the CGI/motion tracking suit for treatment and therapies, possibly as a replacement or additive to exoskeletons?
Okay, it depends on what you're trying to address. Depends on the impairment. I would say, and perhaps implicitly from my talk, you might have got that, whoever asked the question. I think proprioception is important, and how you feedback, the feedback mechanisms. So biofeedback is important, and there's a lot we can do, just visual and motor imagery and so on. But I think that if you, and again depending on the impairment, if you can complement that with some sort of sensory feedback and assistance, that you can progress much further. But it really depends on the individual and the impairment, which brings me to an observation, which is to say, I don't believe that one device fits all. And that's why we are looking on personalized medicine, personalized interventions. So you need to tailor the intervention to the individual, not the other way around.
Okay, great. So our next question, somebody said, hi, bravo for your presentation. I'm a PhD student on medical informatics, and I'm working on serious games for emergency physicians. It seems to be very difficult. And what do we use to find these resources?
Define serious. I mean, life is serious enough, isn't it? So I think you need to, you need to take things with a pinch of salt. And obviously, there are games that might be more appropriate for a different, age group than others. But it's important to understand your patient population or group that you're going to be working with. Mm-hmm. And my advice is always to look at from their perspective, what are the things that drive them. So give an example. In the early days when we were working on the stroke system, we asked our participants to bring on a CD. Back in those days, we were using CDs. Images of their family members and things that they liked, so we could populate the virtual environment with the things that they like. So when they were in that virtual environment, it was familiar to them. Others were about, it's also about goal setting. So if you have someone who had an injury and would like to be able to spend time with their friends, and that means that they need to walk down the pub. You should probably start by asking them, how far is it? And they say, oh, it's 100 meters. All right, let's get you to, get you to walk 100 meters. We will support you to walk 100 meters. So it's about goal setting. It's about, making sure that you do that with your patient collectively, which is very much how our therapists work these days, but most of the time without technology.
Great. And our last question for today is, how is virtual reality used for prosthetics?
Ooh, okay, adding to the videos I already presented, so we have been using it to treat pain, but we are pushing to use it as a way of, for example, learning to use a prosthesis while your limb is still healing, for example. So you might, it's going to be time before you can be fitted with a prosthesis because your tissues are healing, but you can easily be connected to our system. So you could be using it then. And importantly, also combining with the AI is using it in a way that we understand the user rather than, and we map to the user abilities, if you like, rather than the other way around, having to train the user not to use a specific prosthetics. So yeah, that's one of the ideas of what we do.
Okay, great. Thank you very much. So we're out of time and we'll need to leave it there. However, if you could please provide us with your feedback about today's session by filling out our survey, which will be sent to you following today's event, it would be greatly appreciated. And thank you for all of your comments and questions, and a big thank you to you, Professor Rui Loureiro, for an excellent lecture. Have a great evening, everyone.
My pleasure. Thank you all.